Good evening, everyone. Welcome. Thank you so much for joining us for this virtual UMiami Health Talk, Advances in Cataract and Dry Eye Treatments. I'm medical journalist Ileana Bravo, and I'll be your moderator for this evening's webinar, which is presented by Bascom Palmer Eye Institute, the nation's #1 eye hospital. Bascom Palmer Eye Institute serves as the Department of Ophthalmology for the University of Miami Miller School of Medicine. Their mission is to enhance the quality of life by improving sight, preventing blindness, and advancing ophthalmic knowledge through compassionate patient care and innovative research. And for the 23rd time, it has been ranked the #1 eye hospital in the country by U.S. News and World Report. They provide excellent eye care to more than 300,000 patients annually across 5 patient care centers in Miami, Palm Beach Gardens, Naples, Plantation, and Coral Gables. To learn more about Bascom Palmer's corneal and external eye disorder services, visit bascompalmer.org and call 800-329-7000 to schedule a consultation and screening. Don't worry, we're going to show you that screen again so that you can take that number and that website at the end of the presentation. So tonight, our esteemed panel of experts will discuss the latest advancements in cataract and dry eye treatments. This is a highly anticipated call. Many hundreds of you have registered for it, so we look forward to an engaging conversation. Now, at the end of the presentation, there's going to be a Q&A session, which is a unique opportunity for you to become a part of the conversation with our experts, so don't miss the opportunity. All you have to do is use the Q&A feature at the bottom of your Zoom screen. Take a minute to locate it on your computer, and you can submit your questions, and we will tee them up for our experts. So let's kick things off with our first speaker, Dr. Kendall Donaldson, a professor of clinical ophthalmology and cornea specialist at Bascom Palmer. She completed her residency in cornea fellowship at Bascom in 2004 and currently serves as medical director of the Plantation Center and the upcoming Solemia satellite opening this fall. Dr. Donaldson specializes in cataract surgery, corneal transplantation, ocular surface disease, and laser vision correction. She lectures internationally, has authored numerous publications, and is currently the president of the American European Congress of Ophthalmic Surgery. So let's welcome Dr. Donaldson, who has been recognized among the top 100 ophthalmologists worldwide by the Ophthalmologist Power List. Take it away, Dr. Donaldson.
Great. Thank you so much, Ileana. I really appreciate that very kind introduction. Let me share my slides here. All right. So it really is truly a privilege to be here with all of you tonight. This is one of my favorite things to talk about. So modern day custom cataract surgery. So I do have some disclosures. And the objectives of this brief talk include to explain the various types of cataract surgery, to discuss the various types of intraocular lenses that we use during cataract surgery, want to discuss some recent advancements that are very exciting in cataract surgery, and to discuss where we're going with the future of cataract surgery. So to begin, I'd just like to emphasize that cataract surgery is a normal part of life, and I think it's one of the most exciting aspects of life and a great opportunity for all of us. So it's not like other types of surgery, and we can actually embrace it, learn about it, and make the most of our cataract surgery because it can be a life-changing event and can really improve our lifestyle. Cataract surgery is the most common surgery performed around the world. And we are very, very lucky here in the United States because we have all sorts of different types of technology that our patients
Dr.
can
Donaldson.
Dr. Donaldson, we can't
Slide.
screen your presentation. If you would see, you can now pull up your PowerPoint deck. We're having a conversation. We're all in here together.
Oh, you can't see
In
it?
a minute, we'll see your visuals, but
Okay, so
so bear with us for a moment, everyone out there. We should have it up momentarily. There's always a little technical. No, not yet. So we downloaded the PowerPoint. You should have it there somewhere within your site. Bear with us, everyone. Remember, you're going to have the opportunity to participate in the questions. We already have about a dozen questions in the Q&A box coming through. So
yeah. That's right there.
We'll take a look.
Do you see it now?
No, we're not. Any chance, team, that we can perhaps bring up Dr. Martinez, and that way we can let Dr. Donaldson get her deck ready? Is that a conceivable thought? There. Okay. All right, Dr. Donaldson. We see that you have started screen sharing, and all you have to do is give us in the presenter mode.
Are you able to
Here
see
we
it?
go. Thank you so much. Okay, everyone. Thanks for hanging in there. Here we go.
Perfect. So let me skip ahead then a couple here, normal part of life. And so I think we maybe should pick up right here. So we are very lucky to have all sorts of great technology that can really help us improve the lives of our patients, and our patients benefit every day from this great technology that we have as far as lens choices and the technology to remove the lens in a very small atraumatic surgery that lasts approximately 7 to 10 minutes in most cases, unless it's a complex case. So cataracts are the #1 cause of blindness around the world. So much of the world, in much of the world, cataract surgery looks like you see here in these pictures. So cataract surgery is a surgery in the front of the eye. You can see here the lens is indicated here on the left-hand side. So with cataract surgery, we're replacing the lens. You can see other structures in the back of the eye, such as the retina that is affected by macular degeneration, or the optic nerve that is affected by glaucoma, but those things are in the back of the eye. So with cataract surgery, we're working up here in the front of the eye. And this illustration depicts what happens to our natural lens here on the left as our process of aging occurs. And we can see that the lens is becoming denser over time and becoming a cataract here on the right. And here you can see some very dense cataracts here on the upper left and in the center. You can even see some beautiful cataracts, like a snowflake cataract up here on the right. But each cataract is its own unique entity, and they all look very different from each other. But they all are cloudy lenses, and all cloudy lenses scatter light and can cause glare, halos, and blurry vision. So you can see some of those exemplified here. We can see the blurry vision. We can see some scattering of light causing glare. So cataract surgery is typically done with phacoemulsification. Phacoemulsification is the use of ultrasound to break up that cataract, which is a solid, convert it into a liquid, and then that liquid is sucked out through a small tube, as we see here, through a very tiny incision. Cataract surgery can be done in one of two ways primarily. It can be done either with ultrasound or phacoemulsification, as we see here on the left, or it can be done with the assistance of a laser here on the right, which was approved by the FDA back in 2011. So we've had the opportunity to use lasers in cataract surgery for about 14 years here in the United States. There's several different types of lasers that we use to help us with our cataract surgery, illustrated here. These are some pictures of standard ultrasound cataract surgery. Again, you can see that small tube that can suck out the components of the cataract. We can see that the cataract is broken into pieces and then sucked out and liquefied or emulsified. And then we replace the lens with an artificial lens, usually made of either acrylic or silicone, and it will last for hundreds of years, so it'll outlast all of us. And these are some pictures of laser cataract surgery where you can see a laser pattern. Different types of patterns can be applied to the lens to fragment it and soften it so then it can be sucked out of the eye. And these are some pictures before and after. So you can see the cataract there on the left, and that is replaced with an intraocular lens there on the right. So cataract surgery does involve implantation of an intraocular lens in all cases. And so we can see an intraocular lens here. The center area is called the optic. That's where the patient's prescription is placed. And then we have these two haptics, which are like arms, and they help the lens stay in position. These lenses are very tiny. You can see one, you can see several of them here, relative to a dime. It's even smaller than a dime. So the many lens options for cataract surgery, and I'd like to go through some of them. We can see here at the top, this is called a multifocal lens. It has rings of distance, intermediate, and near. And we're going to go through all the different types. There are 6 types of intraocular lenses. A standard monofocal lens is a lens that patients get through their insurance. Those are regular lenses. They can be distance or they can be near. Then we have toric lenses. Again, monofocal means it has one prescription, but it does have the astigmatism factored into it. Then we have extended depth of focus or extended range of vision lenses, as well as multifocal lenses, adjustable lenses, and pinhole lenses. And I'll show you some examples of each of these. So these are standard lenses. You can have them in distance, near, or we can do monovision where one lens is distance and one lens is near. This is an example of toric lenses. So you can see a little mark at the haptic or the little arm of the lens. That indicates the astigmatism, the direction of the astigmatism. And again, these come in distance, near, or we can do monovision again with toric lenses. These are images of extended depth of focus lenses, and that means they have a little bit of an extended range. So they're typically distance to intermediate, but not near. And then finally, we have multifocal lens, which is full range of vision lenses that have distance intermediate and near. And then we have some really fancy things over the last few years, including the first type of lens in the world that's able to be adjusted after it's implanted in the patient's eye. And so this is the light adjustable lens. We use a light source and we can change the power of the lens from distance to near and anything in between. Then we have pinhole optics lenses. As you see here, you can see the darkened area there creates a pinhole effect, which can neutralize some degrees of astigmatism. So unusual eyes like you see here in the center. This is a patient who had radiokeratotomy or RK surgery many years ago. We no longer do this anymore, but their cornea is very irregular, and this pinhole optic can help compensate for that. So which lens is right for each person? And that there's no perfect lens and there's no right lens for everybody. So it's very customized for each individual patient. So I like to share this video with all my patients. I'm going to share it with you now. And it gives you a little overview of how all this fits together.
Cataract is a cloudy lens. It's a normal part of life. As we go through life, just as the rest of us age, our lens in the eye ages as well, and the lens becomes progressively more cloudy over time. So our vision becomes a little worse as time gradually passes, and things start to become blurry. Some patients will notice this with their distance vision while driving. Cataracts can also cause glare. So a lot of patients will notice glare when they're driving at night. The light will be scattered more, so night driving can be a problem. Also, they may need more light to read. So those are the primary symptoms of cataracts. Cataract surgery is a normal part of life. This is lens replacement surgery. So at some point in life, although it may be different ages for different people, we need that lens replaced as that lens progressively grows cloudier and causes our vision to become more blurry. Cataract surgery is about a 10-minute procedure. It's done under topical anesthesia, so we use some numbing jelly so that you don't feel anything. There's no pain associated with cataract surgery. We use some IV sedation to make sure that you're nice and comfortable and relaxed. So it should be a very easy experience for the patient and generally a happy experience because it causes an improvement in your lifestyle and allows you to see better and do more things that you once were able to do, such as night driving more safely. Cataract surgery is performed in one of two ways. Generally, cataract surgery is performed with ultrasound technology. So most cataract surgery is done with ultrasound with a standard distance lens, and that's covered through a patient's insurance. Patients also have other options. They can choose upgraded lenses if their eyes are healthy in most other ways. So an upgraded lens would give the patient more freedom from glasses. However, even with the standard lens that a patient gets with their insurance, they have very high quality vision. And most patients are able to drive without glasses with a standard distance lens through their insurance. Many patients have other conditions such as macular degeneration, glaucoma, or other problems that are not correctable with cataract surgery. So cataract surgery, we have to remember, just corrects the cataract. So we try to give the patient the very best vision possible within the limitations of the other issues that a patient might have. To prepare for cataract surgery, you have a preoperative visit. During that visit, we make some measurements of the eye, in particular, how the eye is shaped and the length of the eye. This allows us to choose the proper lens for the patient. Certain patients may be better candidates for one type of lens or another type of lens. So these measurements help direct us toward what's best for you. On the day of cataract surgery, you'll arrive at Bascom Palmer and the nurses will do some preparation with you, including putting some drops in your eyes that allow us to dilate your eyes very well. You'll meet with an anesthesiologist. The anesthesiologist will determine how much anesthesia is necessary to make sure that you are nice and relaxed for the procedure. Then you'll have the actual surgery, again, which is about 10 minutes. Following the surgery, the bed that you lay on for the surgery sits up and becomes a chair. We give you something to eat, and then you go home. At home, you'll be able to use your drops that same day. Your eye will be covered with a clear shield. We don't patch the eye any longer, so you'll be able to see. However, you'll have a dilated feeling. You'll be very light sensitive and a bit blurry on the day of cataract surgery. As I mentioned, most patients have ultrasound-based cataract surgery. However, laser cataract surgery is an option, and that's what we use for our upgraded cataract surgery. Laser cataract surgery doesn't benefit everyone, though, so not everyone needs laser cataract surgery. The main benefits of laser cataract surgery include the correction of astigmatism. Most of us have some degree of astigmatism. Very few eyes are perfectly spherical, but most patients have just a small amount of astigmatism, and a lot of times we don't even have to correct that. And so patients with just a small amount of astigmatism can have standard cataract surgery done with ultrasound. There are several options for patients at the time of cataract surgery. These options are basically lens options. So cataract surgery has evolved quite a bit over the last 30 or 40 years. At one point in time, it was just the removal of the cloudy lens. However, these days, patients not only want improvement in their vision, they also want more freedom from glasses. And fortunately, we have the technology nowadays to provide patients more freedom from glasses by putting both a distance a prescription, an intermediate prescription, and a near prescription in the same lens. Over the past 20 to 25 years, we also have the ability to correct near vision in addition to distance vision, and that's done with a multifocal lens. A multifocal lens has multiple prescriptions in the same lens. Modern day multifocal lenses can be built with a distance, intermediate, and near prescription in the same lens. The laser does allow us to correct that astigmatism, and we can also use special lenses that are custom designed that have the astigmatism built into them. Now, we do use the laser to assist us with those cases. Again, the upgraded cases are always done with laser cataract surgery. The laser also helps us to use less energy in the eye, so we can use that laser to help pre-fragment the cataract, which is very helpful in cases of dense cataracts. For a very small cataract, moderately sized cataract, again, we don't really need the laser. Good candidates for multifocal lenses are patients that have healthy eyes in every other way. These are patients that present only with a cataract. They don't have any glaucoma, macular degeneration, or other issues with their vision. Many patients that we see may have a history of corneal scarring, a history of infections that limit their vision, and those patients would not be a good candidate for a multifocal lens. Cataract surgery can provide a major improvement in a patient's life, and it's an exciting type of surgery for a patient to undergo. We're very fortunate at Bascom Palmer to have the most advanced technology that we can offer our patients to provide improvements in their life. We look forward to taking care of you here at Bascom Palmer and hope that we can make a difference in your life by performing your cataract surgery. We're very fortunate to have 60 years worth of experience bringing the very latest technology to allow patients to have a wonderful experience with their cataract surgery.
So just to end, the future of cataract surgery involves many exciting things, including robotic cataract surgery that you see here, multiple new types of intraocular lenses that will be able to flex and change from one shape to another to allow more range of vision. We're hoping to get rid of all drops that are used with cataract surgery, and we look forward to helping you with your cataracts and any other eye care you might need. Thank you.
Thank you so much, Dr. Donaldson. So much to ingest there, so much great information. I know that we're going to get bombarded with questions about which lens is right for me.
Thank you. Thank you,
So
Ellie.
let's key up our next speaker, Dr. Jaime Martinez, an assistant professor of clinical ophthalmology and cornea specialist at Bascom Palmer Institute. He completed his residency in Mexico City and a fellowship at Bascom. Dr. Martinez loves teaching, and he's led several eye care mission trips. He lectures worldwide and has authored multiple publications. He was named president of the Young Pan Cornea Society in Latin America in 2023, with research interest in ocular surface management advancements and treating corneal infections. Dr. Martinez, who performs corneal transplants, ocular surface reconstruction, and cataract surgery, is now ready to present. Dr. Martinez, it's all yours.
Thank you. Can you see my slides?
Let's take a look. Yes, you're up.
Perfect. Thank you very much. Well, it's a great honor to be here with you. Thank you very much for the invitation. So I'm going to focus on dry eye treatment. I do not have any financial disclosures in regarding this talk. So dry eye. So first we have to define what exactly is dry eye. And interestingly, there's been a corneal society that is called TFOS, Tear Film Ocular Surface Society. That it's a lot of experts that get together every couple years, and then define dry eye. And the last definition was published in 2017, where they described dry eye being a multifactorial disease that is characterized by loss of homeostasis of tear film with ocular symptoms and also inflammation and potential neurosensory abnormalities. So we're looking forward for the next 2026-2026 TFOS next version. So how common is dry eye? Dry eye, it depends on the place. It depends on how do you define dry eye. It can vary from 11% to 93%. So it's pretty variable and it's pretty common. So to diagnose dry eye, first you have to have signs and symptoms, and you have to exclude other things as well. Like for example, there's also nerve pain, etc. That it can be confused with dry eye. So for dry eye, there's different type of dry eye. We have the aqueous deficiency or the evaporative deficiency. It also can be mixed, so it gets pretty interesting. So for diagnosis, it's important first you can start with a triage questioning, questions such as, if there's any severe discomfort, if there's dry mouth, if there's, triggering factors, if blurred vision gets better with blinking, or other questions such as the use of contact lenses, such as autoimmune diseases that you have. So this is kind of like a quick question just to triage if there's some sort of dry eye. Then risk factors. It's really important to when you see a patient, what kind of risk factors, if they're modifiable, non-modifiable, such as, for example, aging is a risk factors, which I think, young patients with dry eye as well. In female, it's a risk factor, and as well, autoimmune diseases, or also diabetes, rosacea, thyroid disease, also could be also hormonal changes, for example. Modifier factors could be, for example, environmental, the take of antihistamines for allergy medications, antidepressants, and also could be history of surgery, and also smoking and alcohol. So all these risk factors, they're pretty common. You have to see how your patient, it can be modifiable or non-modifiable. So diagnosis tests, there's a lot of testing that we can use. There's a list of testing. We can start first for assessment of questionnaires. So we have great questionnaires. There's a lot of them. You can use it, in clinic or at home. Usually we give it to the patient in the waiting area, and then we can stratify, how bad is the dry eye, if it's mild, moderate, or severe, depending on the symptoms. There's short questionnaires such as the DQ5, just 5 questions, pretty quick, or there's more complex questionnaires like ocular surface disease index. But what about the diagnosis? So when you go into your doctor, you're gonna see they put a lot of drops and things like that. Just to have an idea why we're putting all these drops on my eye, what my ophthalmologist is seeing on my eye that we don't see, of course. For example, we have the tear breakup time, which we use the yellow dye that you can see with the blue light, or sometimes it's green light. And then we measure how much the tear breaks, that I'll show you a video in a minute. Do we have another new kind of new test, osmolarity? If there's a high osmolarity in your tears, it's a machine that has these tears, these strips that we can use for measuring the osmolarity. We have the staining. Also, you can see a lot of like tiny dots on your cornea, or that the stain on your cornea or your ocular surface that can cause that are signs of dry eye. This is a tear breakup time. You can see how the tear kind of like breaks, in the middle. You kind of like, you blink and have the patient don't blink, and then you count how many seconds it takes for this fluorescein to kind of like break down, and that's how many seconds your tear can last pretty perfect. If it's less than 10 seconds, you pretty have dry eye. Less than 5 seconds, so you have really definitely a dry eye that can cause symptoms. We have sophisticated machines, for example, non-invasive, that can count how fast is your tear breakup time without the fluorescein staining. We have also the staining, as I've mentioned. They can also, not the cornea, but also can stain the conjunctiva, underneath the eyelid. So you have to really look into the whole ocular surface, not just the eye. So as I was mentioning, there's different type of dry eye. They can be mixed. So we have the evaporative severity and also the tear deficiency, for example. So how do we differentiate? Sometimes it can be mixed. So that was kind of gets really interesting and a little complicated. But so we have the Schirmer test. You can see these little kind of strips we put on your eyes for 5 minutes. We have your eyes closed for 5 minutes and then count, and then your tear starts like filling up on those tear films, those strips, and that's how much tear do you make in 5 minutes. If you make little tears, like less than 5 millimeters, then definitely you have dry eye, in conjunction with other signs and symptoms. And also, if you have a lot of tears, then you probably have other type of dry eye, right? They have also the tear meniscus height. So we measured the tear that builds up between your eyelid and your cornea, which is the front part of your eye. We measure it. There's a special machine to measure that, and then that's a sign of dry eye. So with the meibomian gland dysfunction, so we have these glands that we have in our eyelid. You can see in the bottom picture, you can see here kind of like some errors that you can see. This oil that we can press on a little bit on you can press on the eye examination, and we can see how it squeezes, and you can see this oil coming out. And if it's pretty clear, it's good. But if it's kind of oily and kind of like hard to press, then you can have this meibomian gland obstruction, right? We have machines also that can test that, the meibography or the interferometry, that we can see the dropout. You can see there's a gray and white picture in the bottom right. You can see there's no gland there. That means that gland definitely just atrophy, maybe die because it was obstructed, and there's basically it just dies, and you don't have that. So you have a lot of we have scales on how to measure this, the meibomian scale. So if you have how much glands you have on your eyelids, and if you don't have any glands, then definitely you don't have the lipid layer producing every time you blink. You have machines that do that, like the lipid view. And then other options, you go to these stores and you have a lot of options. So I'm going to kind of go one by one overall different options for dry eye treatment. So also, there's a lot of questions about the use of supplements. This is being a big research and clinical trials. Like, for example, omega has been studied for omega-3, some controversial results on these omega-3. Some patients, they say it helps. I've seen some results also. It shows that it helps for dry eye. Antioxidants also has been published that helps for dry eye. But you also have the negative factors such as alcohol, smoking, diabetes, etc. So we got to also take that in mind. So eyelid hygiene, this is really important, really important. Sometimes we, forget, that we do have eyelashes that we have to really clean them. Use hot compressors can help to those glands that you can see. I'll show you a picture how this looks, those glands where they're really like toothpaste kind. So that heat helps to make that lipid more easy to be removed, and then cleaning really well as well. Those eyelashes, because you can see underneath those eyelashes, you can see a lot of debris on that. So this is one of the meibomian gland expressions treatments that we can use. Sometimes we use Q-tips, so we use these special forceps that you can see that toothpaste coming out like really like interesting. And it's some patients they found really relief from doing this treatments. But also we have automated machines, so we also have technology that can help to squeeze those glands and help those glands to stop of blocking them, because they can atrophy, they can be destroyed basically if you get blocked. So we have this machine that can give you heat, meibomian gland expression. We have a LipiFlow also, that's a 12 minutes procedure that you create some heat and also kind of like milks these glands as well on your eyes. So we have that also IPL, that's like the light treatment that help for this patient that have a lot of vessels that get engorgement, like redness, and down around their their eyelids, in the eyelid margins. That helps to reduce that as well, that vessels inflammation, creating dry eye symptoms. So there's also a lot of treatment. So which is the best drop for me? There's a lot of options. There's like lipid-based, water-based, jelly-based. So which one the best for me? So the first thing you have to know is there's different layers of tears. What's the tears made out of? So we have the different layers on the tears. We have the lipid layer, which is the outside, which is more oily. Then we have the water base in the middle, and then they'll have the mucin layer also in the mucus type in the bottom, like touching your cornea, your eye. So depending on your symptoms, your signs, this is how we know which drop is best. So you have just a tear breakup time really quick, that your lipid just breaks up really quick. You have lipid-based drops that you have to use. If you have like don't make any tears, you need more. You have more water-based, just hypotonic, hypersmaller drops. If it's gel type, that's as well. Ointment, you use them at night, because that causes a little bit of blurriness, and patients they can't work with this gel kind of like feeling and blurriness with these ointments that are pretty thick. So we recommend that use it at night. And also, if you're using a lot of it, it's important to use preservative free, because also preservative is the overuse of these tears can cause also redness and inflammation. All right. We also have other prescription medications. We have, for example, we have the Liftigrast. This is for patients who have inflammation on their eyes, and this is medications such as cyclosporine that have the generic and also the brand type. This is for patients that have inflammation, because dry eye can cause inflammation. So it's kind of like a never-end cycle, where you have the dry eye and then causes inflammation, and then potentially pain, and it goes back dry eye. So it's a never-end cycle. So in patients that have like inflammatory type of dry eye, you have to as well treat it besides the lubrication. And so we have, you also have to take in mind that these drops didn't work right away. They take some time, and they also have side effects. You have to talk to your doctor. We also have the low production. So, there's some patients that are like, I can't, I don't cry, I don't have any tears. So that's why we have the test, the Schumer test, and we have options for that. We have such as the punctum plugs and other options. So punctum plug. So punctum plugs, basically what we do, we put a plug on your tear duct. We have two tear ducts in the upper lid and lower lid that we block the tear duct to drain, so you have more tears and more often. And there's different options for plugs. We have like these ones that you're seeing right now is the collagen based. We have a silicone, they're permanent, or the collagen that they last short period of time. You can talk to your doctor about different options for what's best for you, what's pros and cons. We have the Lacryfil, another, I'd say it's a kind of like a gel they inject on the tear duct, and then it lasts for about 6 months, and then you have to replace it. So it's another option to block the tear duct. So those patients that they make not much tear, and they found relief by blocking the tear duct, so they have more tears. Also, we have, everything is connected. So the lacrimal gland, we have nerves that stimulate these tears, and they have nerve connections with the nasal nerves. And there's a lot of product that have been shown some stimulation of these nerves, such as this one. You can see this buzzing effect on your nose. Some patients don't like it. This is a eye tears that create these like stimulation of the nerve to create more tears. We also have the Tervaya nasal spray, which it's a spray that basically stimulates the nerves of the nasal side, and it stimulates the lacrimal gland to produce tears. Sometimes causes sneezing. There's one of the side effects, etc. So also amniotic membranes is this little membrane we use to help healing as well in certain cases. Serum tears. Serum tears drops out of your own blood. Many patients, they get scared. How am I going to use drops from my blood? Well, it's really common, especially in patients who have severe dry eye. So they drop blood, and then there's different type of serum tears, but there's different percentage. And then you put it in a little vial, spin it, get the serum, and then put them in vials, and then they get refrigerated, and you can use it on your eye. It really helps a lot of healing of the dry eye. We have surgical that as a last resource, like putting glands from your lip, so your lip to your eye. That's really just as a last resource thing. It's not really common to use. And also contact lenses, it's also used for dry eye, especially the sclera lenses. Actually, the sclera lenses are really good treatment for severe dry eye. They're a little bit bigger, and they can keep the eye moist. So in summary, dry eye, it's really important to diagnose what type of dry eye, look at the risk factors, use different kind of diagnosis, and to be able to treat according to the symptoms and signs. Thank you very much.
Thank you, Dr. Martinez. Wow, blood serum tears. That's fascinating. People are going to be asking about that one. So let's launch into the Q&A session, because as you well know, you've both been trying to answer through that box as many as you can feverishly. So let's try and get right to it. Let's start with this one. How do the newer post-op adjustable lenses work? Because that's the latest and greatest, very 21st century. But what are the pros and cons? Just because they're new doesn't make them better. Traditional versus adjustable.
So the newer light adjustable lenses work generally by doing the two cataract surgeries pretty close together. I typically like to do them a week apart. That way we can limit some of the extra visits post-operatively, because we can adjust both eyes at the same time. The first adjustment typically occurs 3 weeks after the second surgery. So then we meet the patient for the light adjustment. We do some trial lenses, so we actually simulate what the patient's vision would be after the light treatment. So the patient can actually take part and pick what they would like. So they can say, you know what, I might need a little bit more near or intermediate vision. And then we put that in a little trial frame. The patient tries it on. They walk around, they look at the computer, and they say, I like this, or I want to do a little bit more of this and that. And then we do the light treatment once we decide. And then after the light treatment, they go home, they live with it for a week or two, and then they come back. And they say, well, that was better. I have a little bit more computer distance vision, but I'd like a little bit more of this or that. So we do another trial frame, we simulate, and they say, oh yes, that's what I'm talking about. Then we do another light treatment. So each eye can have up to 3 light treatments. Sometimes one eye might need 1 light treatment, the other might need 2, so it can vary depending on which eye is the dominant eye or the non-dominant eye, but they can have up to 3 adjustments right now.
But
So
it isn't for everyone.
it's not everybody needs that kind of adjustability. Sometimes the eye's perfect, we could tell what lens the patient would need, and they don't really need to adjust it. However, we have a lot of patients now that have a history of LASIK or PRK or RK in the past. And some of those patients who've had multiple prior surgeries, it can be a little more difficult to know exactly which lens is best for them. So in complex cases like that, sometimes I like to use the light adjustable lens. So it helps me kind of make sure I get to where the patient wants to be.
When does someone know, I guess if they go to their eye doctor, ophthalmologist on a regular basis, they can look deep into the eye and see the cataracts are forming. But can you know intuitively, like, there's something wrong with my vision, there's something wrong? What's dry eye, severe dry eye versus cataract? Any of either.
Sorry, severe dry eye or cataract? Oh, yeah. So some patients, they can cause blurry vision from dry eye. So some patients, they think they have cataracts. developing, but sometimes, age is it's a risk factor for dry eye, but also cataract. So both things can either happen at the same time, or it might be, one more than other. So that's a really thing that we have to look into, that depending on the eye exam. There's it's not a cataract and the blurred vision is there, but there's a really high, signs and symptoms of dry eye. Then first you have to treat that, and then and maybe cataract in the future if there's no cataract. Yeah.
I saw one of the questions that came over about hormonal changes. Um, can that menopause and other hormonal changes exacerbate or created either of the things, or is allergy medication another contributing factor?
Yes, dry hormonal changes has been really as a risk factor as for dry eye, and as well allergy medication, Zyrtec can cause dry eye, and it's really common to take Zyrtec, patients allergy, especially here down in Florida. So it's also a risk factor for dry eye. So you really put more often drops you're going to use if you need it, for your allergies.
Dr. Donaldson, are glares, floaters, any of the halo effects are normal post-cataract surgery, and do these side effects disappear with time?
Great question. So floaters are completely separate from cataracts or cataract surgery. So we all get some floaters over time. In fact, it's normal. We always think 60% of patients by the age of 60 will have some degree of floaters, and they may be more noticeable in certain situations versus other situations. Now, sometimes right after cataract surgery, a patient may notice their floaters a little bit, they might be a little bit more pronounced in a small percentage of patients because we are making the vision clearer. So sometimes right after cataract surgery, they might see everything a little bit clearer, including their floaters. And then the brain kind of tunes that out over time. And so it goes back to the normal level. But floaters can also be symptoms of other retina problems like retinal tears or retinal detachments. So if someone has a new floater or new shower floaters, they should be evaluated to make sure they don't have a retinal problem. Now, as far as glare and halos, that's a whole nother issue. Cataracts do cause glare and halos. And so a lot of patients come into our office because they're having glare and halos. They're unable to drive at night any longer. So that's a common symptom. In fact, it's one of the most common symptoms of cataracts. And it's worsened by dry eye because dry eye also causes glare at night. So you put those two things together, like Dr. Martinez was saying, these patients can really be suffering from several things that cause glare and halos. Now, there also are some lenses that we use during cataract surgery, such as multifocal lenses, that can cause a little more glare and halos in some patients. So that needs to be discussed, and when you're with your doctor, and we want to make sure that you're not a patient that's going to be in a high risk group that would have side effects like the glare and halos, from certain lenses. So that needs to be fine-tuned for each individual patient.
Dr. Martinez, this question for you. Advancements in dry eye treatments other than the Restasis and the Xiidras and all the commercials we all see on television. What's the latest and greatest right now? Does it vary by patient? And when does it get to the point of those extreme options such as surgical in order to correct and resolve?
That's a really good question. There's in terms of, there are new medications coming on the market. It just takes a while to get it approved. But in terms of patients who are severe dry eye, such as patients that have especially autoimmune diseases or history of radiation or history of chemotherapy, things that are high risk for developing severe dry eye, or history of chemical burns and things like that. Graft versus host disease, for example, that's one of the diseases that causes severe dry eye. We tend to get more in terms of like treatments more aggressive, like serum tears. There's serum tears that they're high percentage, or plasma-rich growth factor, something we didn't talk about, but it's a little kind of like serum tears, but more with growth factors, or scleral lenses is another option. Salivary gland implants, the one I mentioned, that you transport salivary glands from your mouth to your eye, is not common. It has been described for a while, but it's still something on the research and what's the best technique, and it has been improved over the last years to get the best effect, because sometimes the effect doesn't last. These glands you put in your from your lip to your eye, it might not last long enough. So there's a research that we're looking into in the future, and also maybe in the future regenerate cells, to be able to get more glaucoma grafts. Something that still in the future, but not yet we have it right now.
And piggyback off that question, I know someone else asked, what are the causes for the dry eye when it's at night? And is it treated differently when it's, I guess, nighttime, sleep time, dry eye?
Yeah, dry eye at night, I tend to I recommend patients, depending how you never know if they're sleeping with their eyelids a little open. So it's hard. Sometimes there's patients, they have a little tiny opening when they're sleeping and they don't realize that, and these patients, we recommend like gels or ointments, try to during the night, because then those ointments can cause blurriness. So it's hard to work with an ointment, on your eyelids, ocular surface. It causes blurriness. So you got to be careful. You have to tell this patient, if you're going to do gel or ointment, be careful to not, if it causes blurriness. So maybe use it at night where you sleep, and try to use the fan, the air conditioning away from your, hitting your head, on your bedroom. So that's one of the things that I recommend.
Dr. Donaldson, are we seeing cataract at an earlier age? Is it a product of normal aging? Is there anything we can do to protect ourselves, protect our eyes, do lifestyle changes in order to prevent them?
Yeah, that is an amazing, great question, Eliana. So yes, we are doing cataract surgery at a younger age. So right now, the mean age of cataract surgery is 67.7 years. And so if we look at what the mean age for cataract surgery was, 10 to 15 years ago, it was more like 75. So it has gone down for several reasons. It's not that people are developing cataracts really at a younger age. It's that we're tending to do cataract surgery at a younger age. And a lot of that is due to the technology that we have available. The cataract surgery, if we think back to 1970, they weren't even putting lenses in the eye. People had those Coke bottle glasses, and cataract surgery would be hours long, and people would be admitted to the hospital for a week. And now, it's much smaller procedure. And so it's done a little bit earlier. In fact, I think LASIK, people have had LASIK in the past and all that. And so people are used to having great vision. And so they're not accepting, waiting until their vision gets so bad. Our demands for our vision have increased so much. So a patient doesn't want to wait until their vision's gone down 6 or 7 lines and they can no longer drive. They want to maintain their independence. They want to stay young. And so, the people are wanting to have cataract surgery at a younger age. So I think it's exciting. And luckily, technology is so great, we could deliver this to them at a younger age.
Yeah, I guess that must be it. It's sort of like more in the conversation, so it's not so scary. And now with the technology, it's advanced so much. Here's my other question. Um, how about vision changes over the years after you've had the cataract surgery? Can that happen too?
So your vision actually is quite stable after cataract surgery for the most part. What causes vision to decline over time is that lens growing over time. So the lens is getting thicker, which changes your prescription, causes the vision to get blurry. And so that's what that process of vision loss is. It's the lens changing. So once you have cataract surgery, your lens will stay the same size. It's no longer going to get thicker. It's no longer going to get cloudy. Now, some patients need some polishing done, but that's not on the lens itself. That's on the capsular bag, which is the clear structure that contains the lens after cataract surgery. But your vision will remain stable for the most part. Now, you can still develop things like glaucoma or macular degeneration or diabetic retinopathy, and all those diseases can affect the vision in another way, but your lens is not going to start growing again or opacifying again for the most part.
Dr. Martinez has just given us a great question, and this one's for you. And then I'm going to go back to you, Dr. Martinez, on this other question. But so this person says, if we want to see all 3 distances with cataract surgery, but I don't want to risk seeing halos and other side effects, what is the best option? This person says, I wear the readers from the drugstore and that's it. The rest of the cataract surgery is for my distance.
So With a multifocal lens, that's the lens that will give you the most freedom from glasses. You can have a risk that has the highest risk of glare and halos. So if you want absolutely no glare and halos, and a patient tells me that I absolutely want zero glare and halos, then I won't put a multifocal lens in, because that's a little bit more difficult to predict. So in those patients that want the highest quality of vision, but they want more range of vision, I'll use the light adjustable lens in those patients. And you don't get glare and halos with that lens.
So would you say that now, in 2025, you're doing more of the adjustable, more of the multifocal, or is 50, 60, 70% of them still the traditional one?
So I'd say right now about 40% of what the lenses I'm implanting are premium lenses or upgraded in some way and customized in some way, about 40%. So about 60% of my patients are still getting standard lenses, but that might also mean they might get some monovision. So I might be doing, one eye more for distance and one eye more for near. So we still might be customizing it to some degree, but I'd say about 40% of my practice is an upgraded lens at this point.
And my understanding, just if you could clarify for the audience as well, the upgraded lenses are not necessarily covered by insurance.
The upgraded lenses are not covered by insurance, ever.
Yeah. Okay, Dr. Martinez, here's the one that we think is perfect for you. Dry eye caused by glaucoma. What can be done about that? And you're muted.
Sorry about that. It's really common to have patients that have a lot of glaucoma drops and have symptoms of dry eye. There's a lot of publications regarding that, so it's really important to talk to your glaucoma specialist and see if they can modify the treatment, because there's also preservative-free glaucoma drops, and also could be, maybe surgical procedures to avoid, or laser procedure, other procedures that glaucoma can do to be able to have less need of drops. You remove, you need the drops. If you need the drops, you need them, but so you can talk to alternative treatments to avoid having a dry eye secondary to glaucoma drops.
Great question that just came over. I'm now monitoring the box because it's still blowing up. Is there any age limitation for cataract surgery?
No, there is no age limit for cataract surgery. But that being said, I don't like to operate on patients that are sickly or over the age of 95. It's really better to do it before you get to the point where your health in general is an issue, because by the time we're in our 90s or 95 or beyond, our healing is less predictable. It's harder on us to recover, to go through that process. Whereas if we're in our 70s and 80s or we're healthy, it's a much easier recovery process. And that's true for any surgery that we're undergoing. You don't really want to wait to that level. And also, if we wait to that point, the cataract is so dense sometimes that it takes more energy to take the cataract out, and then the patient develops more swelling during the healing process. So we prefer to get the cataract out before a patient becomes compromised, systemically as a person.
Dr. Donaldson, a person who is cortisone sensitive and saying that after cataract surgery, is there another drop or another thing that they can use? Because I know that part of the post-treatment for the cataract is the cortisone, steroid drops, etc.
Very good point. So we do use steroid drops after all of our ophthalmic surgeries, and about 20% of patients can get a little bump in their intraocular pressure after when treated with a steroid. There are some low dose steroids, though, that are less likely to raise the pressure. And so we typically switch to one of those lower dose steroids that don't raise the pressure as much. Sometimes we might have to stop the steroid entirely and use a non-steroidal drop, such as, a relative of aspirin or a relative of Motrin, for example, instead of the steroid. The steroid just works so effectively. We'd rather use the low dose steroid if we could. So that does work. And sometimes we have to stop it early if the patient can't tolerate it, or we might have to add a pressure drop just temporarily. So sometimes I'll continue the steroid and add a pressure drop and say, okay, we're going to do this until we're done the steroid, and then we'll stop them both at the same time.
I think it bears a conversation also with our patients or the people watching tonight. Is there anything we can do from a lifestyle standpoint? Obviously, diabetes and many other things can contribute to bad things happening in the body, including damaging the eyes. Is there something that we should be doing, protecting our eyes better from the sun when we're out in the sun and at the beach and playing golf?
I would say just staying healthy in general. So taking care of yourself in general, exercising, eating right, that type of thing, just having a healthy lifestyle, controlling our blood sugar. We only can control so many things in life, but taking control of those things and having a healthy lifestyle helps with all of these things we're discussing, whether it's cataracts or dry eye. We live in Florida. We need to protect ourselves from the sun for so many reasons, not just eye health, but skin health and just in general, skin cancers and things like that. But we just have to think about a healthy lifestyle in general.
And sometimes the cataract surgery leads to dry eyes. So Dr. Donaldson sends them over to Dr. Martinez. And
Oh,
Dr.
she can do it.
Do you find that a lot? That the post cataract surgery, they present now with the dry eye, and now you have to treat that.
So I wouldn't say we find that a lot, but I would say a lot of our patients are older, and so maybe they have some underlying dry eye. So any surgery that they have can cause them, whether it be cataract surgery, which is a smaller surgery, or corneal transplant or retinal surgery, any of those surgeries can make the patient feel a little bit more dry afterward. And part of that's because we're putting medications on the surface of the eye, at least temporarily, that have preservatives that dry the eye out. After any surgery, you can be a little bit more dry and then you get back to baseline. Now, a small percentage of patients, less than 1%, can feel like their eyes are drier long-term after cataract surgery or any eye surgery that we do, but typically they're patients that have underlying dry eye.
And I'm going to ask you both to give us a quick wrap up, the minute wrap up, because I think that this has a lot of hope for people tonight who are watching and saying, "Oh, I can get relief. I can get help. I can go to the #1 eye hospital in the country and get some help." So, Dr. Martinez, just take us home with your message on how to treat dry eye, how to take care of ourselves, what we can do to keep our eyes healthy and circumvent these conditions.
Yeah. So I would say that dry eye for the most important is to have a healthy life, eat healthy, really antioxidants help, avoiding a lot of smoking, alcohol, things like that can cause dry eye. See your primary ophthalmologist to be able to diagnose what type of specifically of dry eye, and not just being putting drops like crazy over the counter, because we've seen like from CDC reports that also been risk of infection or for using certain drops. That's also really important. So really talk to your primary care physician, primary care ophthalmologist about for what's the best treatment for dry eye for a specific situation.
So you can actually do more harm than good by doing excessive of the wrong drops. That's
Yes.
good thing to know. Dr. Donaldson, your volume is up, I hope, so we can hear you strongly. And there you go. And just give us some final words tonight on the condition of cataract surgery in the 21st century, today, 2025, how people can really get relief and great vision and great sight.
Well, Ileana, this is a very customized question, and I think that each patient should address that specifically with their doctor to see what opportunities they have with their cataract surgery. People shouldn't be suffering from blurry vision from cataracts these days because we have so much that we can offer patients. And, if a patient really educates themselves as far as all the options, they can take part in this process and in this discussion with their doctor to help them make their best choice. So I think educating themselves and playing a role in the process of choosing the right lens and all of that really can be helpful for them, and it can change the rest of their lives. It's a wonderful opportunity.
Yeah. Well, we thank both of our experts tonight for the privilege of their time, for sharing their knowledge and their expertise and improving our lives as a result. So thank you for taking the time. There's the information. Our talk has come to an end, but as I promised you all, there's your information again. So if you'd like to contact Bascom Palmer, bascompalmer.org. And for appointments, it's 800-329-7000. You can scan the QR code and go ahead and get the information from there. But we thank you all for being an interactive audience. Dr. Donaldson, Dr. Martinez, feel free to say goodnight to all of our folks watching us tonight.
Great. Thank you all. We
Thank
really
you.
appreciate you being here with us this evening.